We all know that peri-operative systemic therapy, especially FLOT, is the standard of care for locally advanced non-metastatic gastric cancer. Many residents whom I interacted with recently, when asked this question, why is peri-operative systemic therapy better than upfront surgery followed by systemic therapy, all had the same answer: FLOT trial. Did FLOT trial actually prove that perioperative systemic therapy is better than surgery followed by systemic? And if not, why is periop systemic better than upfront surgery? The NCCN discussion part, all these referrals take us to the well-known classical trials with the same conceptual outline. The comparator arm had surgery alone, and the other arm had surgery followed by adjuvant therapy or perioperative systemic therapy. All of these trials proving that this arm did better than this arm alone. A meta analysis of 15 randomized controlled trials, all with the same problem. The comparator arm was surgery alone. And the most widely quoted FLOT trial compared this versus this and said FLOT is better than ECF. If you notice, none of these above trials compared or tried to answer the question that we are trying to answer in this video. Why is this better than this? Why is a periop systemic therapy better than doing upfront surgery followed by the same systemic therapy? Two trials published till date answered this question: Prodigy from Korea and Resolve from China, comparing peri-op systemic on one arm, surgery followed by systemic on the other arm, both clearly showing a survival benefit for perioperative systemic therapy. But the most important reason why peri-op systemic is better can be understood by looking at this slide. In the MAGIC trial, the first peri-op systemic trial, which proved that this is better than this, when they started the ECF, 86% could complete the first three cycles of ECF before surgery, but post operatively, only 41% could complete all three cycles. Very similarly, in the FLOT4 AIO, which compared ECF periop versus FLOT periop, in both the arms, the preoperative treatment completion or ability to complete all the planned cycles of chemotherapy was good. In both the arms, the postoperative treatment completion rates were low. These are actual number of patients from the ISOPEC trial. 207 started on FLOT, 193 completed the first four cycles, but after the surgery, only 142 were started on adjuvant FLOT. 118 of them completed all the four FLOT cycles. So the most important reason why periop systemic is better is that in the postoperative period, after a gastrectomy, the ability of a patient to tolerate intensive cytotoxic chemotherapy, especially FLOT, is significantly reduced, so that in by giving some systemic preoperatively, we are enforcing that at least some systemic has gone in. So after the surgery, if the patient is not able to complete all the three, if the patient is able to take only one or take two at a reduced dose, we are enforcing that at least some systemic therapy has gone in, and that's going to help the patient. So that is why globally, except Japan because of their JCOG0501 trial, globally, periop systemic therapy is the standard of care for any locally advanced non-metastatic gastric cancer. If for some reason an emergency surgery is done without preoperative systemic therapy, it's not a crime, it's not wrong, it's justified in some circumstances. In that case, if the surgery is adequate, that is, an R0 resection achieved with a D2 lymphadenectomy, adjuvant chemotherapy is enough. If an inadequate surgery is performed, that is, a R2 resection or a less than D2 lymphadenectomy, adjuvant chemoradiotherapy may be required. to improve the local regional control. And this new arm is because 10% of gastric cancers are MSI high, and unlike all the cancers all over the body, MSI high cancers respond poorly to systemic chemotherapy. Hence, neoadjuvant immuno is being considered in these patients.